Greetings, online students. I am now going to be covering some more of your head-to-toe physical assessment that you will need in order to successfully do that. Today, I've already covered Roman numerals 1 through 5 in different sections, and now I'm going to be covering the eyes, the nose, and the sinuses. So if you'll get your handout out from your syllabus, then we'll go over that and take some notes and see where we need to go from here, and I'll come back at the end and give you a little more information. Alrighty, let's see here. It may take me a minute to find it, a minute to win it. Let me just go back in here and pull it up. Alright, if you'll go to your syllabus and you'll go all the way down, just a little reminder, you'll have 45 minutes to do this by memory, your head-to-toe physical assessment. You can do it by coming to campus and setting an appointment with me in the near future, or you can do it online through YouTube, or posting it as a recording and sending it on a jump drive or a thumb drive. Either way you want to do it. And I'll be getting with y'all soon to figure out who's going to do what. To pass it, you have to achieve a 70% or higher on the physical exam, adhere to the time limits, demonstrate organization, arrive on time if you're coming to campus, bring the necessary equipment and supplies as requested by faculty, and I've been going over what you'll be needing, or if it's something that you need to check out here with me, you can do that. Prepare for the exam in a timely manner, introduce yourself and explain the procedure. Make sure you're allowing for privacy, even if you're doing this at home. Use equipment and supplies correctly and safely, which I have been doing videos to show you how to do that, so I would expect that when I see you doing it, that you are doing it correctly. Performs the physical exam in an organized, systematic manner, and consistently pronounce terms with correction. And then if you fail, you got below 70, you didn't adhere to the time limits, you lacked organization, you arrived late, you didn't have your equipment, you failed to perform it in an organized manner, you omitted lots of things, you didn't explain, you failed to use the equipment correctly, failed to provide privacy, consistently pronounced incorrectly terminology, and incorrect or unprofessional terminology. Alright, so you remember you're going to do a psychomotor component, and you're going to do a write-up of whoever you do this on, and you're going to turn in that write-up as well. And you're going to use pages 784 through 785 as a guide to your write-up. Alright, so you always remember, going to start out by washing your hands, introducing yourself, collecting vitals. If you do this ahead of time, remember, then you can say I've already collected the vital signs and they were within normal limits or whatever they were. Then I'm going to start my general survey, remember, and I went into the dress, the appearance, the mood, the affect, orientation, and gait. And then I have covered all the way down to the eyes, through the ears. Excuse me. Now on the ears, I didn't go over, but make sure when you're looking in someone's ear and inspecting it that you're holding the scope upside down. You don't go in holding it upside right, because if they jar, that could go into their ear and could cause damage to the eardrum. So let's start on the eye and the nose and sinuses, which would be cranial nerve number 6 and 7, so what I'm going to be covering. On the eye, there is going to be some cranial nerves in here, and either you can do the cranial nerve assessment all at once at the beginning, or you can include it throughout as you're going. That will be up to you. As long as you cover them all, I do not care. The cranial nerve assessment is part of this week's assignment on pages 633 through 637, shows you how to test for each cranial nerve. In week 9, I will be posting this video of how to do, again, Roman numeral 6 and Roman numeral 7. When you look at your criteria here, it says first thing you're going to do is inspect the external eye. And it says here the first thing you're going to do is start with the eyebrows and looking at the lids. If you look on page 292 in your book, it starts with the eyebrows. And it says you're going to be looking for symmetry. Usually they're bilateral and symmetrical on the face with no scaling or lesions noted. So that's what you would say about the eyebrows. Again, that they are present bilaterally, and there's no scaling or lesions, and they're symmetrical. When you're looking at the eyelids and eyelashes, of course, they should overlap just a little bit, but there shouldn't be any swelling, any drainage, or any lesions noted, and the eyelashes should be evenly distributed. When looking at the lacrimal apparatus, it talks about that on page 294. You're going to ask the person to look down, and with your thumbs, you're going to slide the outer part of the upper lid up along the bony prominence, and that will expose the upper under the lid. And you're going to look for redness or swelling. So when you do that, you take your thumb, you slide the outer part on the upper lid along the bony orbitance. Again, you'll be able to see under that lid, and that's what she's doing on page 295. And you're looking for redness or swelling. So you would do that, say there's no redness or swelling, there's no excessive tearing noted. So no redness, no swelling, no tenderness, no excessive redness noted, and that's your lacrimal apparatus. Your conjunctiva, when you're looking at that, that's on page 293. It talks about that, as well as your sclera. As the person looks up, and this is on figure 14-16, you're going to slide the lowered lids down over the bony orbital rim. Take care not to push, of course, against the eyeballs. Inspect the exposed area. It should look moist. There should be clear. So they should be clear and moist. There shouldn't be any swelling. There shouldn't be any lesions. There shouldn't be any redness or bloodshot unless they are tired. Now, the sclera itself should be white, although occasionally it can be a gray, blue, or muddy color if it is a African American and dark-skinned people. May even have some freckles or a petechii on their sclera. So you would look at the sclera and you would just verbalize what you see. Again, it should be clear and white and not bloodshot. So you're looking to see if it's bloodshot. So you're looking at the conjunctiva. It should be pink and moist and glossy and clear. And you're looking at the sclera, and it should be white and clear. And it may have some, like I said, some bloodshot veins in it as well. Then you're going to palpate all those things. You're going to palpate the eyelashes, the eyebrows. You're going to palpate the lacrimal apparatus and see if there's any tenderness noted. The next thing that it says you're going to look at is the extraocular movements. The extraocular movements are cranial nerves number 3, number 4, number 4 and number 6. And that would be ocular motor, trochlear, and abducens. And the way you're going to check for this is checking for the positions of gaze, or the cardinal fields of gaze. And let's see where it talks about the cardinal fields of gaze in your book. Should have wrote that one down. Well, the cardinal fields of gaze, what you're going to do is take and put your finger in front of the patient about 12 inches away from their nose, and then starting in a clockwise manner, you're going to take your finger to the outside and bring it back in. Take your finger to the outside and bring it back in. And do that clockwise, and do that like you're doing it around about 6 times around a clock. And that's on page 291 at the bottom. The Diagnostic Position Test, or the Positions of Gaze. Again, leading your finger through the 6 cardinal positions of gaze, what you're going to be doing is eliciting any muscle weakness during movement. So you're asking the person, hold your head steady and follow the movement of my finger, pen light, whichever, only with your eyes. Then you're about 12 inches again from the person. You're going to have them comfortable, and you're going to do the 6 positions and progress clockwise. A normal response is parallel tracking of the object with both eyes. So both eyes should work. Eye movement that's not parallel or failure to follow in a certain direction indicates a weakness of those muscles. So if you got one lagging behind, you would know they have some weakness of their eye muscles. The 6 cardinal fields of gaze or position of gaze. Then you're going to check for accuracy, and we're not going to do the cover-uncover test. Check for accuracy of acuity, and you're going to do this again through the Snellen eye chart, cranial number 2 optic, and it describes how to do the Snellen eye chart in your book on page 288, so be sure to read over that. Normal vision, of course, is 20/20. Instead, and if you want to know what the numbers are measuring, the top number, the numerator, indicates the distance the person is standing from the chart, so it should be 20 feet. The denominator gives the distance at which a normal eye could have read that particular line. Thus, 20/30 means you can read at 20 feet what a normal person can see away at 30 feet. So normal is 20/20 vision. Again, if they have glasses, you want them to do that with their glasses on or their contacts so that they could see. And you would write that like right eye 20/20 with glasses. Left eye 20/30 missed one letter, you know, whatever they did. Okay, you may not, and also if the person's over 40, you would want to have them read something like a magazine or a newspaper, checking for near vision, because we start having trouble with that as we get older. If you don't have a Snellen eye chart, then you can borrow one here, or if you've already done it by the time you start your assessment, you can include that in your vital signs by saying, I've already done the Snellen eye chart, optic number 2 is intact. To check, test papillary reaction to light and accommodation, that should be the same cranial nerves. I'm sorry, I left one off there. It should be 3, 4, and 6 again. And the way that you're going to test for reaction to light and accommodation is just that. You're going to have a pin light, and you're going to check and make sure that the light is reactive to that. It talks about this on page 295. You're going to look and see if they were like at a 4 and then you had the pin light and they dilated to a 2, then you would say they went from a 4 to a 2, because we know the light's going to make them constrict. The left eye went from a 4 to a 2. So that's how you document that. So the pupillary reaction to light is strictly that. Check each eye and how the pupil reacts to the eye and constricts. Accommodation is a little bit different. With accommodation, this is on page 296, you test for accommodation by asking the person to focus on a distant object, like the wall. This will dilate the pupils. Then you have the person shift their gaze to a near object, such as your finger, which is about 3 inches from their nose. A normal response would include 2 things: pupillary constriction and conversion of the axes of the eyes. And it shows the example of that on page 296. So you would expect them to constrict and to converge. And that's testing positive for accommodation, which cranial nerves number 3, 4, and 6 again would be intact. Then you're going to inspect the internal eye and check for the red reflex. Note that the student used his right eye, will use their right eye to the patient's right eye as well as the left eye to the left eye. Otherwise, you're going to be smooching them. And you have to complete an internal eye exam. So the first thing you're going to do is dim the lights, and you're going to check, and I gave you a video that showed you how to set the diopter and what to look for. That was very, very neat. So hopefully you have watched that. To check for the red eye reflex, again, you're just going to make sure you turn the light out. As you turn the light out, you will come in at a 15-degree angle, about 10 inches away. And this talks about this on page 298. And you'll see a red glow filling the person's pupil. That's what we call the red reflex. Now, this is simply caused by the reflection of your light off the inner retina. And that's just making sure that your retina is intact. If you can't find that, they may have they may have problems with their retina, or they could have cataracts. That's letting you not see that red eye reflex. As far as looking at a complete internal eye exam, if you start on page 300 and look at that, with the lights dimmed and going right eye to right eye and left eye to left eye, you'll complete the internal eye exam. So you will follow the patient once you're at that 15-degree lateral line. You'll bring your view into until you find the optic disc. If the disc is not in sight, then you're going to track the blood vessels, and as they grow larger, it will lead to the disc. A normal ocular fundus is shows you that on page 300, where you can see that, and then there's the normal optic disc down here. So again, if you follow all your bigger veins, they'll usually lead together around that optic disc, which shows you that on page 300. The color of the optic disc is usually creamy yellow-orange. It's usually the round circle, or it could be oval. And it does vary upon looking at it. As far as once you find the optic disc, then you're going to look at the retinal vessels. You're going to look at the number. This is on page 301. Arteries and veins. The vessels look straighter at the nasal side. In your eyes, they are opposite. The veins are bigger than the arteries. The arteries are bright red, and a lot redder than the veins are. They have the arterial light reflex. Arteries and veins show a regular decrease in caliber as they extend, so they get smaller as they extend away from the disc. And then you will see what's called the macula, and that's on the bottom of page 301. You'll see the optic disc it shows you the veins around it. Then usually if you go straight across from the disc, you'll see a darkened red area. That is your macula, okay? A bright light of this area causes some watering sometimes and discomfort. So just note that as you're getting ready to check for that. So you're going to do a complete internal eye exam looking at those things: the optic disc, the retinal vessels, the background, and the macula. When you're looking at the background, there shouldn't be any hemorrhages, there shouldn't be exudates, a lot of swelling, things like that that you're looking for. Then you're going to test the peripheral vision bilaterally. When you're getting ready to test the peripheral vision, this is on page 289. The peripheral vision is doing the confrontation test. And when you do the confrontation test, this is a gross measure of peripheral vision. It compares the person's peripheral vision to your own, assuming you're normal. So if you don't have normal peripheral vision, you cannot perform this. But you're going to position yourself at eye level, about 2 feet away from the person. You're going to direct the person to cover one eye with a card and the other eye to look straight at you. And you want to cover your own eye opposite to the person's covered eye. So you cover the opposite one. You are testing the uncovered eye of the person. So hold a pencil, or you can flick your finger a little bit at a target midway between you, and then slowly advance it in from the periphery in several directions to see when the person sees it. You will ask the person to say now on the top of page 290 as they first see the target. This should be at about the same time you see it as well. With the temporal vision, you start the object somewhere behind the person and bring it up. And they should see it roughly at around 50 degrees upward, 90 temporal, and 70 down. If a person's unable to see an object like you do, then that says they have a loss of peripheral vision, and they would need further testing. The cover-uncover test is on page 290. You would want to do the cover-uncover test, and this test detects small degrees of deviated alignment. The macular image has been suppressed or covered by the eye, so you cover one eye, and then you remove remove that from the eye. Now uncover the eye and observe it for movement. and it should be staring straight ahead. If it's jumping all around, then that indicates the eye muscle weakness exists, and you would repeat that for the other eye. And they, again, are having some alignment issues. So that's to see if their eyes are remaining normal. So you'd want to check for that as part of your peripheral vision. The cover-uncover test and doing the peripheral vision on the test of visual fields on page 289. Excuse me. So there's a lot to the eye. So that's why I'm covering it extensively, so there will be no surprises. Now with the nose and sinus, this is worth 8 points. First, you're always going to start by inspecting the external nose, the position, patency, acuity, and sinuses. So you're going to feel, of course, you're going to look at the nose and see if it's symmetrical, if it's positioned, if there's any deviation. Check for patency by having them plug one part of their nose and breathe in, and then plug the other nose. As you can tell, I have a code. And then you're going to check the sinuses. You're going to check the maxillary and the frontal sinuses. The frontal sinuses you would push up under the eyebrows and upward to see if they have any pressure or pain. They may feel some pressure, but they shouldn't feel pain. Then you would do that under the cheekbones and press them upwards to see if they have any pressure as well, or pain on your pressure. Then you're going to, again, like I said, palpate the nose, see if there's any kind of pain or tenderness when you palpate the nose or the sinuses. Then you're going to inspect internally the nose for deviation, and you're going to check for landmarks. So when you go into the nose, and this is, let's see here, page 359 in your book is where it starts talking about inspection of the nose. Most people like to wear gloves during this part when they are inspecting the nose as well. You want to attach, when you're getting ready to look at the nasal cavity and inspecting it for deviation and landmarks like the mucosa and the turbinates. This is on page 360 in your book. You want to usually use a speculum. If you don't have that, then you want to use a pen light so that you can look up the nose. And you would have them gently tilt up their head back as you gently tilt the tip of their nose with your finger before inserting. You would view each nasal cavity with the person's head erect and then with it tilted back. You're inspecting the mucosa, noting that it's normal red color and smooth. So it should be red and smooth. It tells you over to the side there if it's swollen and bright red, they may have an upper respiratory infection. If there's a lot of discharge, this is common with a cold, rhinitis, or sinusitis. And it can vary, of course, from watery to colored. And with chronic allergies, when you look at the mucosa, it may be very swollen, pale, and gray. So if you look up there and it looks pale and gray, then they've got chronic allergies. If it's bright red, bulging, and swollen, then suspect rhinitis. Discharge, suspect sinusitis and rhinitis together. So again, as you look into the nose, it should be just a normal red color and smooth. There shouldn't be any swelling, discharge, bleeding, or foreign bodies. Then when you get ready to look in the turbinates, it shows you there as you're looking into the turbinates, you will only be able to visualize the inferior and the middle turbinate. The superior turbinate is located way back to the back of the nose, so you would not be able to see that one. Observe, again, as you're looking into the nose for deviation. A deviated septum is common, and it's really not significant unless airflow is obstructed. And then, of course, then you're going to need to check it out. There shouldn't be any perforation or bleeding in the septum. Page 361 shows you a picture of a deviated septum. You can see how the nares have different sizes because they have a deviated septum. You're going to also be looking for polyps while you're in there. Because there shouldn't be any polyps around the normal turbinates. Polyps are very smooth, pale gray, mobile, non-tender areas that look to be swollen. Okay, it shows you again on page 361 how to feel of the sinus areas, the frontal and the maxillary. And then how to do transillumination. So let's say you looked into the nose and you seen that it was bright red and they've had an upper respiratory infection, then you would want to do what's called transillumination of the sinuses. If there's no evidence to support problems with sinus or they don't complain of tenderness, then you wouldn't want to worry about that. But all you do is take your light and you put it over the area of the sinuses, and you won't be able to see the light underneath the skin because there's too much fluid in there. All right, then you're going to test for olfactory, which is cranial nerve number 1. You're going to have 2 scents. Don't let the patient see which scents you have. You're going to have them close their eyes. You're going to have to close off one of their nostrils, have them breathe in and tell you what the scent is, and then have them close their eyes as you get the other scent ready, and have them breathe in and tell you what that scent is. And that's how you check for cranial nerve number 1, olfactory, and you would say that it's intact. As you get ready to do your physical assessment, you will have to tell the names of the cranial nerves as you go. Okay, that concludes Roman numeral 6 and 7, the eyes, the nose, and the sinuses. If you have any questions about this content, please feel free to get in touch with me, and I'll do my best to go over anything that did not make sense. Okay, thank you, and I hope this helps.